Good afternoon, bon après-midi tout le monde. We have simultaneous interpretation for today's session. So if you'd like to access it, please click on the globe at the bottom of your screen and select the language of your choice. Bonjour, mesdames et messieurs et tout le monde. Nous avons de l'interprétation simultanée aujourd'hui. Si vous voulez accéder à la service, s'il vous plaît, sélectionnez le globe en bas de votre écran et sélectionnez le langage que vous préparez. Merci. Et s'il vous plaît, nous allons utiliser menti.com. We're going to be using menti.com and there'll be an access code shortly to see, but if in advance you want to open menti.com on your device or in a browser, we will be using it.
Sarah, I just noticed that two people have their hands up, Catherine Gagnon and Bekele Hankebo. I'm sorry if I mispronounced her name. Should we just, oh, okay, Catherine, she lowered her hand. Oh.
If you have a question, feel free to put it in the chat. Si vous avez des questions, s'il vous plaît, les mettre dans le chat. Oh, good. There is a code for Menti and it will be shared in just a couple of slides. Donc, il y a un code pour Menti et ça va être partagé dans quelques secondes. Si vous êtes juste ici maintenant, donc il y a de l'interprétation simultanée en anglais et en français pour le webinaire aujourd'hui. Et pour l'accéder, il faut sélectionner sur le globe en bas de votre écran et choisissez le langage que vous préférez. If you're looking for simultaneous interpretation for today's session, please click on the globe at the bottom of your screen and select the language of your choice. We'll start in just a moment.
Hello, everyone, and good afternoon. Thank you so much for joining us. We're just delighted to see the interest of hundreds of Canadians in this really important topic for today. I'm Margaret Eaton, and I'm the very proud National CEO for the Canadian Mental Health Association. I want to begin by acknowledging that our national office for CMHA is on the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples, and it's now home to many diverse First Nations, Inuit, and Métis people. CMHA is committed to advancing truth and reconciliation, better supporting Indigenous communities, and working as allies with Indigenous mental health organizations to advocate for increased access to Indigenous-led mental health services. We've been working with our Federation-wide Truth and Reconciliation Working Group on a goal to decolonize and indigenize CMHAs across Canada. And this is a lofty but important goal. We know that working together, we can truly move reconciliation forward. I'd like to start by just telling you a little bit about CMHA for those who may not be familiar with us. We were founded in 1918, and we are the most established, most extensive federation of not-for-profit community mental health organizations in Canada. Through a presence in more than 300 communities across every province and the Yukon Territory, CMHA employs 8,000 staff and engages 11,000 volunteers. We provide advocacy, programs, and resources that help to prevent mental health problems and illnesses. We support recovery and resilience, and we enable all Canadians to flourish and thrive. And CMHA has a really powerful vision, a Canada where mental health is a human right. But what does that mean practically? And how can we measure our progress as a nation towards this vision? Well, we actually undertook the research that we're about to present to you with that goal in mind. So today, I'm delighted to welcome you here to launch our report on the state of mental health in Canada. And really, we feel this is a milestone moment for Canadians. For the first time in Canada's history and our Federation's history, CMHA is providing a picture of the mental health system with all its cracks and failings. Our report puts a stake in the ground, choosing 24 key measures to show how well we're managing our mental health addictions and substance use health issues in Canada. The picture we paint in this report is a deep and thorough dive that reveals the cracks in the system. And very frankly, we are just not doing a good job of caring for people who are experiencing psychological suffering in our country. But I know we've all known this for decades. You know this, we know this. But finally, we have the facts as a country and for each province and territory to really paint a detailed picture of what mental health care in Canada actually looks like. We hope that this enables us to better advocate for mental health substance use policy change and investment, and to raise public awareness about the issues we see impacting our communities across the country. This report helps show that mental health and substance use health isn't funded on par with other healthcare services. It highlights inequities among Canadian provinces and territories and identifies areas needing attention. It reveals the choices that governments are making, and it also reveals how people in Canada are actually doing in different parts of the country. Most importantly, we hope that this will compel decision makers to act. So thank you so much for your time participating in today's webinar. We look forward to sharing a copy of the report when it launches on November 19th. And we really look forward to working with you to create and advocate for the system we all want and need. So to speak to this report, I'll now introduce my colleague and lead author of the report, Dr. Lena Lowe. She is our Senior Research and Policy Analyst, and our brilliant National Director of Research and Policy, Sarah Kennel. Lena, over to you.
Thank you so much, Margaret. And it's such a pleasure to be here today to talk about mental health and the release of this new report. The number of people here today, and I think we're at 982, which is a lot, really shows that Canadians are interested in and are really concerned about the state of mental health. And what this new report really shows is, as Margaret had just mentioned, is that there are things that are not working as they should be in our mental health care system. And we hope that this report, when it's released, will compel you to join us in advocating for change. At CMHA, we really strongly believe in the power of evidence and data and how it can be actioned to make improvements to our mental health care system. And we hope that that's conveyed through this presentation and that you'll join us in making this call. So as Margaret mentioned, this report will be released on November 19th. So what we're going to do here today is we're going to give you a little bit of a sneak peek of some of the key findings. And along the way, what we're going to do is we're going to test your knowledge about the mental health care system in Canada. But first, let's take a little tour of the report and also explore some of the context for why we decided to do this work. So this report helps fill some gaps in knowledge about what we know about the state of mental health and the healthcare system in Canada. It really helps us tell a story about how the system works and where it needs improvement. So you might be wondering, what kind of gaps are we trying to fill? Well, first, and there's three. So the first one is that our mental health care system is very fragmented. And as you'll see in this presentation, so is the data. We really don't have a clear picture of what's available and in terms of the quality of the data. So we really wanted to understand what data are and aren't available and how our system is being used and how it's performing. Second, our aim was also to take a more holistic approach to mental health. So recognizing that mental health is much more than the care that you get through a doctor's office or in a hospital. So we wanted to look at things that help keep people well, like access to housing, employment, rates of discrimination, where we're getting care and who's providing that care. And third, as Margaret mentioned, this approach really helps us think about how Canada is doing when it comes to supporting mental health and the human rights of people across the country. So the Canadian government has signed on to international treaties that say that Canadians should have the right to the highest attainable standard of health. But we wanted to know, is this really true? Is this really the case? This report is really evidence driven, and that means that the picture we're trying to sketch out is driven by the data. So what kind of data were we looking at for this report? The first is that we were interested in national published data, so statistics and percentages that could be broken down by province and territory. We were interested in data that really covered three main areas. So the first one was population mental health. We were interested in things such as how many people die by suicide in a given year, how many people die from opioid toxicity or overdoses, how are people rating their own mental health, what is the prevalence of mental illness and substance use disorders in the population. We are also interested in quality of life data. So what are the rates of housing need for people with poorer mental health? What are the rates of discrimination? At what rates are people employed or unemployed? And how does that connect with mental health? We're also interested in service use data, which is what people often think of when they think of healthcare data. So hospital data, access to physicians or family doctors. We're interested in the number of mental health providers across the country. How often are people hospitalized repeatedly for mental health and substance use problems? How many psychiatrists are practicing in Canada? So when we looked at this data, we ended up taking it from Statistics Canada, from the Canadian Institute for Health Information, the Canadian Medical Association, and the quality of the data was really important for this research. And so we only picked data that had sufficient coverage to make it comparable across the country among all the provinces and territories. The second thing that we did is we wanted to look at policy data. And as you can imagine, this isn't data that's well available. So it's data that we ended up sourcing ourselves, and it's qualitative. So we're interested in the laws and policies that shape mental health care services across Canada. So that includes things like Mental Health Acts, which are provincial and territorial acts that govern psychiatric care in hospitals. We're interested in budgets and how much governments spend on mental health care. We're interested in things like strategies and frameworks for mental health and substance use and addictions, and things like harm reduction policies. So this is data that we found ourselves, and that we created an assessment grid to be able to determine how well that policy was performing. And policies are really important because they have important implications for our mental health and also for our service access. So we felt it was really critical to include them. The third thing that we did, and as Margaret mentioned, CMHAs are located across all 10 provinces and 1 territory. And what we wanted to do is to look at this data and see what CMHAs, which are frontline service provision and providers, what they thought about the data, and also what sort of innovations were happening in their own province or territory. And we wanted to get a sense of whether that data resonated with them, and whether that data was telling the whole story or whether there were missing pieces. And so we were able to find out some very interesting innovations in mental health and substance use healthcare that we'll share later on in this presentation. And the structure of this report, I know you don't have it in hand yet, but the structure of the report is such that it's organized by profiles. And so the first starts off with a profile that showcases all the indicators across Canada. And there's a total of 24 indicators. So as you can imagine, it's a lot of data. And then following the Canada profile, the data is also broken down by province and territory. So you're able to get a sense of how that province or territory is doing against the Canadian average. Now, let's kick off the tour of the report with a quiz. So I'm going to turn it over to my colleague, Sarah Kennel.
Thank you so much, Lena. And a special shout out to the friends and family we have listening in today. Bienvenue tout le monde. C'est super de vous voir aujourd'hui. We're going to kick things off with a little quiz. And the first question is, what grade would you give our mental health system? So the Menti should be open now. You can either click take a picture of the QR code, and I see many of you are doing that already, or you can go to menti.com and enter the code 95940058. Now, we have a whopping 1,082 participants and climbing in this webinar. Our goal is for as many of you to complete this as possible. What's interesting is the live results are showing that folks have different perceptions of the mental health care system, and perhaps some of a more optimistic view, others perhaps indicating that we have work to do. Lena, what are your thoughts on what folks are thinking?
Yeah, I'm seeing the results are stacked in the C's, but it's also high in the D's and the F's. So I get the sense that there's a lot of frustration in terms of access to mental health care, at least from this group. So for this report, and I see people can continue voting, but what we found in the report, we didn't give letter grades, and there's a reason for that. And it's because policies and the mental health data really performs differently on different indicators across the jurisdictions. So we didn't want to give broad strokes letter grades. But what we did find in the report is that there's a lot to be concerned about. So even before the pandemic, what we found was that 2.5 million Canadians needed healthcare, and specifically mental health care, but weren't getting it. And that's about equal to the population of Manitoba and Saskatchewan combined. So during the pandemic, mental health really did suffer. We experienced service closures, job losses, stressors on mental health. Mental health providers and healthcare providers were under stress. There was isolation and a lot of distress. And during the pandemic, we saw that the rates of poor mental health tripled, going from 8.9% in 2019 up to 26% in 2021. And we also know that not all groups experienced their mental health in the same way. And what we found is that an alarming number of Indigenous people reported poor mental health. So 38% reported poor mental health compared to the general population. We also saw some other critical areas of concern. The rates of opioid poisonings jumped and from 3,500 in 2019 to just over 8,000 in 2023, making Canada the second deadliest country in the world for opioid poisoning deaths, right after the US. And what we found is that support for harm reduction has been wavering, and that simple possession or charges for simple possession still accounts for 2/3 of reported drug offenses, which means that people are still being criminalized for using drugs, even though the federal government issued guidance to stop prosecuting people for simple possession. We also saw the rates of alcohol consumption going up, and during the pandemic, there was an increase in hospitalizations due to alcohol. And so it climbed to about 279 hospitalizations per 100,000 in 2021, up from 259 per 100,000 people in 2019. And it's only starting now to decline, fortunately. And in this report, we highlight that areas where the system can be made stronger, and we're pushing governments at all levels to make that change. But we hope to show in this report that it's not all doom and gloom, that there are areas where the system can be made stronger. And what we're doing is we're pushing governments to make that change. And we're also offering solutions and areas of hope for improving mental health care across Canada. So I'm going to pass it to Sarah, who I believe has another quiz for us.
That's right, Lena. On to the next quiz. So as you know, funding is a huge part of the story when we talk about the strength and capacity of any system, whether it be our education or health or any area where governments are making decisions around what we should be spending resources on and how we should be allocating those resources. So Lena, in a couple of moments, is going to speak to how the research uncovers what provinces are spending on mental health. So this quiz is to get a sense from you. What do you think that provinces are spending on average when it comes to the mental health care system as a percentage of the overall health budget? So I'm seeing some interesting results here. Majority of respondees at this point are saying it's around 6%. Some are in the 25% and even the 50%. So very interesting spread of results, Lena, would you say?
It is. And if you guessed 6%, you're right. So what we found in this report is that no province or territory is spending what it should on mental health. On average, provinces and territories are actually only spending about 6.3% of their overall health budgets on mental health. And what we think is that they should be spending closer to 12%. So let's unpack this a little bit. What we did in this report is we did an analysis of budgets for each province and territory. So we looked at the spending for the 2024-2025 year and looked at the spending for mental health as a proportion of the overall healthcare spending. And then what we did was we found each for every province and territory and then averaged it out. And that's how we got 6.3%. Of the provinces and territories reporting, most, and that's around 80%, were spending less than 7% of their healthcare budgets on mental health. So among them, the lowest spenders were Northwest Territories at around 4% and Nova Scotia at around 4.9%. And the highest were Nunavut around 10% and Saskatchewan around 7.5%. The 6.3% is really lower than the target that was set 12 years ago. So back in 2012, the Mental Health Commission of Canada had released a mental health strategy that said that Canada should be spending between 7 and 9% of the healthcare budget on mental health. That was 12 years ago, and here we're spending less than that target. So you might wonder why we're saying 12% as the threshold for spending. And that's because that's what's in line with what peer countries are spending. So for instance, in France, around 15% of the budget is spent on mental health care. In UK and in Sweden, it's around 9%. And in Germany, it's 11.3%. And of course, when we look at this in terms of millions of dollars, it translates into quite a lot more money spent on mental health compared to Canada. And here you can see from the handy map, and this will be released along with the report, that there's a nice little tool that gives an analysis of spending for mental health care in Canada. And I believe we're at quiz time again. So Sarah, you're up.
We are. So the next question is, when we think about the implementation or administration of the system in relation to other healthcare services, the question is, when did mental health and substance use health become fully integrated into our public universal healthcare system, or Medicare? And some of you are including very interesting discussion in the chat around the different roles that the private sector or community-based organizations play in the delivery of mental health and substance use healthcare services. So the question now is it really part of our public universal healthcare system? And if so, when did that happen? So interesting results at Confederation in 1867, in 1984, through the enactment of the Canada Health Act. In 2015, our last major change election in Canada at the federal level, or 2020 ? Has it not yet happened, perhaps? Lena, over to you.
All right, and this was a little bit of a trick question. So if you guessed the last option, which was 2020 or 20 ? You would have guessed correct. So as it stands, the mental health system is made up of very crudely stitched together private, public, and not-for-profit services. It's not actually part of the universal system of healthcare that we have known as Medicare. The fact that we're releasing this report now and talking about this now is really timely. This year marks the 40th anniversary of the Canada Health Act, or Medicare, which was introduced in 1984. And that was a really pivotal moment in Canadian history because it means that hospital and physician services, doctor services, became something that would be universally available in all provinces and territories. What happened with the introduction of Medicare is there was a creation of a conduit for the federal government to create transfer payments to the provinces and territories. And so that became an essential part of providing universal care for hospital and physician services across Canada. And so what did this leave for mental health? So essentially, it became up to the provinces and territories to use their own funds, their own revenues, to be able to sustain mental health, addictions, and substance use care. And that really produces gaps, which is what we'll explore in this presentation. So provincial and territorial governments under Medicare are not required to fund community mental health services. So community mental health workers who are providing services from healthcare settings by social workers, crisis responders, educators, counselors, and peer support workers, these folks aren't covered, and the services that they provide aren't definitively covered under the Canada Health Act. And why does this matter? And it means that access to care might be limited, and what's available, it will be limited. And of course, whether you have to pay for it or not is a factor. So Sarah, you have another quiz for us.
I do, and that really sets us up well to answer the question, at a personal level, has the cost of mental health care ever been a barrier for you or a loved one? And what we're seeing in the chat is that this is a deeply personal issue, and there are communities that are disproportionately impacted when it comes to inequities or unevenness in terms of access to the systems and supports and services that we need to be well. So it looks like the vast majority of respondents here are expressing what has come through in the qualitative and quantitative research so clearly, that many Canadians, many people in Canada, in fact, millions of folks, don't have access to the care that they need when they need it.
Yeah, overwhelmingly, it looks like people are responding yes, that's the case. And it really points to the fact that it's really difficult to talk about mental health care in Canada without talking about money. And there's a few reasons for that. So the first is that, and what we found in this report, is that there's an undeniable link between mental health and our material conditions, including where we live, whether we have a job, and also one that pays well, and whether we have income supports. And the second point is that cost is a barrier to mental health care, and living in poverty jeopardizes our access to the things that we need to be well. So first, let's explore the link between mental health and these material conditions that I mentioned. So what we found in the report is that people who live in poverty are more likely to have mental health problems. In Canada, people in the lowest income group report having anxiety 2.4 times more often than those from the highest income group. It also affects housing. What we found in the data was that Canadians with poor mental health are 50% more likely to live in inadequate housing. So that means housing that costs more than what they can afford in terms of their incomes. It means that the housing might be inadequate for the size of the household, or that it's in need of major repairs. And that's compared to the group reporting good mental health. So on average, about 15.8% of Canadians with poor to fair mental health lack adequate housing, compared to around 10% of Canadians with good mental health. We also found that around 50% of people with mental health disabilities are employed, which is shocking because it means that a huge proportion of the population is unemployed or relies on income supports. And this is important because meaningful and well-paying employment, we know, are factors for good mental health. And we also know that when people don't have access to employment, when they have to rely on things like income supports, these are mechanisms that keep them in poverty and that further compromise their health and their access to the supports that they need to be well, including healthcare. So because mental health care isn't universal, most psychologists, counselors, social workers, and many other treatments aren't covered by provincial and territorial insurance plans. So people often have trouble accessing these services unless they can pay for them. So what we found in the data is around 57% of young people, and that's around the ages of 18 to 24, who had early signs of mental illness, said that cost was an obstacle to getting mental health care services. And we also know that the rising cost of living means that people sometimes have to make tough decisions about whether they're going to pay for rent or afford mental health care. Kelly, you can go ahead and change the slide. Okay, thank you. So an important finding in this analysis is that, excuse me, an important finding of the mental health policies in this report was that the pandemic really was a critical time for mental health. It was a time when mental health concerns were talked about in a very public way, but also a really disappointing time because the policy action on mental health didn't present permanent solutions to fix our healthcare system. So during the pandemic, the government had promised to introduce a mental health transfer, which, if any of you remember, was supposed to be a dedicated source of funding and direct federal transfer to the provinces and territories to deliver mental health care. And it's to recognize that there's a shortfall and that mental health care services aren't provided through the Canada Health Act. But unfortunately, that didn't pan out. And instead, the federal government struck temporary agreements known as bilateral agreements with the provinces and territories. And a problem with those agreements was that there was no requirement to spend those federal funds on mental health. And so in 2023, the bilateral agreements covered 4 different areas of healthcare. And we just released a report called Overpromised and Underdelivered. And in that analysis, we found that around 15% of that funding was going to mental health. And in this report, we also look at the 2023 funding and also the 2017 funds that were left over from a previous bilateral agreement. And we found that that funding is close to 30%. This is obviously a smaller pot of money and much smaller than our overall healthcare budget. But the fact that it's such a small percentage of the funding just raises concerns about this being a too small and a temporary fix for a bigger problem in funding for mental health care. What we also found through the agreements is that the provinces and territories are not required to fund community mental health services. And so the services delivered by people like social workers, crisis responders, educators, counselors, and peer support workers aren't covered, aren't the ones that are being funded through the bilateral agreements to the same extent as hospitals and other forms of services. We also found that during the pandemic, the federal government did introduce other services that we also considered to be more of a temporary or quick fix. The government had introduced Wellness Together, which is a self-directed mental health service that offered some counseling support. And unfortunately, that was closed down earlier this year in the spring. The government also introduced 988, which is a national crisis line to assist people in crisis. We recognize, though, that this isn't a fulsome approach to addressing mental health crisis and that there's a wider range of crisis supports that need to be available that have not been yet planned for or made available through the service. We also note that a major gap is that the mental health strategy is way out of date. So a lot has changed since 2012 when the initial strategy was released. We've had the opioid crisis, rising rates of homelessness and encampments. We're really dealing with an affordability crisis. There's less support for harm reduction now among governments, and there's more government talk about involuntary treatment for substance use, which is worrisome and raises some human rights concerns. Ultimately, there really is a need for careful and long-term thinking about mental health funding and policy in Canada. Over to you, Sarah, for the next quiz.
Thanks, Lena. And with that planning in mind and from a strategy perspective, a big part is around health human resourcing. Do we have enough of the healthcare workers needed to really ensure that our system is sustainable and meeting the diverse needs of diverse populations? So one of the indicators that we looked at was around coverage of psychiatrists across the country. So the question that we ask to you all now is, how many psychiatrists do you think practice in the 3 territories combined? With the answers being 15, 8, 4, or 12. I'll just let folks respond. And this is just a reminder. We've seen so many great questions come in through the Q&A and also lively discussion in the chat. We are going to do our very best to get to as many questions at the end as we can. Just a reminder, if you have a question, if you could put it in the Q&A function, that would be awesome. And Lena, I've already got a few teed up for you, so this is going to be fun. All right, so in terms of responses, it looks like we have a really well-informed group here of folks. The answer is 4, which is a shockingly low number when you think of the proportion of oh, I'm sorry, I'm going into the next slide. Lena, back over to you, the expert.
Thanks, Sarah. That's a great segue into this section of the presentation. So yes, 4 only for combined for the territories. And you might be able to guess at why this is a concern. So in this report, we found that the mental health landscape looks drastically different depending on where you live in the country. And that's in 2 ways. So the first is that population mental health differs by province and territory. And secondly, that service access also looks different. And that's in part because the service infrastructure and the funding are different. So let's break this down a little bit. So when we think about some of the differences among the provinces and territories in terms of population mental health, we see differences in harm, for instance, across the country. So the rates of self-harm are extraordinarily high in the Northern Territories. They're about 3.5 to 5 times higher than the rest of Canada. Thinking about opioid-related deaths, many of you are probably familiar with how the opioid crisis is hitting Western provinces or Western Canada the hardest. So in Alberta, BC, and Yukon are experiencing some of the highest rates of death due to opioids. In BC, that number is 46.6 deaths per 100,000 last year. And as a comparison for all of Canada, that rate was 20.8, so that's more than double. We also find that rates of discrimination across the country vary widely. So for example, in Quebec, the data showed that the experiences of discrimination from people who report poor mental health is about 5.6 in Quebec, and that the national average was about 9.1%. And BC reported some of the highest rates of discrimination at around 10.9%. And there's much more detail in the report on these different measures across the data that you'll be able to explore very soon when the report is released. We also found that there is a great unevenness in services across the country. So as mentioned through the quiz, psychiatrists is an excellent example of this, with only 4 practicing in the territories. We found in Prince Edward Island, there's about 8 of them, compared to a total of 747 in BC and a whopping 1,938 in Ontario. And of course, that data doesn't tell the whole picture, because it really matters also where you live in the province as to whether you have access to psychiatrists. So we know, for instance, if you live in rural and remote parts of Ontario, likely you don't have as many practicing psychiatrists, whereas a lot of them are clustered in urban areas like Toronto and Ottawa. We also found that emergency department visits for mental health and substance use health concerns were much higher in provinces like Alberta. We noticed and we found in the data that harm reduction was a particularly strong suit in British Columbia, with many great examples of programs and initiatives, but that there has been waning support for it. And we also found examples, for instance, in PEI, where there was appetite in the government to be able to introduce things like supervised consumption sites, but where there's also local opposition, which makes setting up those services really difficult. Another example is that in Saskatchewan, we found lower than average access to services for youth. So young people are just having more trouble being able to access services. And in fact, there was a crisis declared by the Saskatchewan Advocate for Children and Youth, noting that there's just a high need for services for youth and just not the level of access needed. We also noted that privatization of services across Canada is becoming a bigger and bigger problem, and that's especially the case in Quebec, where most people are having trouble even finding a family doctor. We also noted that, that there is a much smaller number of mental health providers in the northern areas of Canada. And so in places like Nunavut, people often have to fly in and fly out of their communities down into southern urban areas to be able to access treatment. And on the flip side, service providers are also flying from urban areas up into the north to be able to provide needed services. And across the board, there's also equity concerns. So we know that the experiences of mental health and service access are also shaped by social inequalities. So things like racism, colonialism, poverty, whether you're urban or rural. And in several northern territories, there are many communities that have declared states of emergency due to the highest suicide rates. And we know that this is an issue of racism and many years of colonialism, as well as a lack of necessary health infrastructure in the north. All right, if you can change slides. So there are significant problems with our mental health care system, and I hope that this data that we're presenting so far is really highlighting that. We also want to show that it's not all doom and gloom, that there are good things happening in Canada that we can look towards as innovative approaches and solutions for our mental health care system. And these really could be expanded across the country. So this map, it's a nice little map that will be released along with the report, and we'll invite you to have a look at it once the report goes live on the 19th. But I'm just going to walk you through some of these innovations. So as an example, and first, in Nova Scotia last year, the government introduced the idea of a new and universal publicly funded mental health care system that would provide free counseling to Nova Scotians. In BC, we've seen important investments in mental health promotion, the types of services that help prevent illnesses and catch symptoms early on so that people don't end up in crisis or with poor mental health. We've also seen in Alberta significant investments in addictions treatment, and especially for bed-based care and residential care, which is badly needed and of course is a struggle in many parts of the country. In BC and Ontario, we've seen boosts in funding to community mental health. So those particular provinces have put more money into investments in community mental health. In BC, Ontario, and PEI, we've seen the development and introduction of mobile crisis response led by civilians. And so this is crisis response that's not police-based. And so the people responding when somebody calls 911 or through a dedicated line is for civilians and trained mental health professionals who can offer services and supports. We've also seen in Saskatchewan, New Brunswick, and Newfoundland, in Labrador, rapid access mental health services to be able to reduce wait times. Because we do know that across the board, wait times for community mental health services is a huge challenge, and people aren't getting access to counseling and therapy that they need. In Ontario, we've seen the expansion of free psychotherapy. In PEI, we've also found a dedicated emergency department for mental health and addictions, which is excellent because it means that people don't have to wait in a general emergency department when they're in crisis and in a place of vulnerability. We've also seen the introduction of youth wellness hubs in New Brunswick and BC, which essentially is a no wrong door approach to healthcare, and that also offers social supports. In Yukon, we've seen rural wellness hubs that bring together health and social services. In Nunavut, and to respond to the lack of mental health professionals, we've also seen initiatives where people are being trained, training community members known as paraprofessionals to be able to deliver services in the community so that people don't have to leave to access services. We've also seen the funding of child psychiatry in Saskatchewan, which of course we know that as a subspecialty, it's harder for children to be able to access psychiatrist services. In Nunavut and Yukon, we've seen the introduction of land-based therapies that really emphasize the healing power of land and nature for mental wellness, and do so in culturally appropriate ways. In Manitoba, we've seen the funding of a wellness program for farmers. As we know, there are particular mental health challenges in the agricultural sector. And Quebec has created an up-to-date and really strong mental health strategy. And we wanted to highlight the strategy because just having a really strong mental health and addiction strategy makes planning for mental health for the future really important in terms of ensuring that we have good funding and good service infrastructure when it comes to mental health. Next slide, please.
Lena, just before we move on, maybe, I think a lot of folks are adding in their thoughts in the chat, and I think this is a great opportunity for folks to highlight innovations in their own communities or best practices, things that are going well. As you mentioned, a lot of our conversation is often dominated by what's not working, what the gaps are, what's going wrong. And I think this is a real moment for us to have hope in identifying what those best practices are and planning for the future and really organizing to support those as best that we can across the communities in which we're located. So back over to you.
That's wonderful. And Sarah, if there's a way that we can somehow save the chat history, that's something great that we can take back with us, to include in future reports, because this is going to be, this is a new flagship report that we're releasing that we hope to update every 2 years, but highlighting innovations is really key to building on and building a stronger mental health system.
Absolutely. And just before we talk about hope, there's an area that is of particular interest to you being, I don't want to call you a nerd, Lena, but I call you that with all the affection in the world. You are our expert and subject matter expert in this space. Do you want to speak to some of the challenges that you encountered as you started to look under the hood across particularly some of those quantitative data sources?
Yes, and this is definitely not a sexy topic, but really what this report showcases is that we need better data. We need to be collecting more of it, and we need to be collecting better quality data, because really you cannot fix what you don't measure. And so some of the problem areas that we identified in the report can be summarized in 4 points. So the first is that we just don't have enough data about our mental health system. So we want to know who is accessing care, what are the care pathways, what are the service needs that people have. We're not collecting very much in the way of mental health promotion data. Like, what are some of the upstream interventions, and are people able to access them, and how is that preventing and changing service access in the future? There's also not enough data we found, and this is of a particular interest to us, on the community mental health sector. And there's also problems among the data that is collected in community mental health that make the reliability challenging. So for instance, wait times for community mental health counseling is something that we were going to initially include. But when we started digging into the numbers and seeing what the coverage of participating mental health organizations was, we found that the data didn't accurately reflect what was happening on the ground in terms of access for counseling among CMHAs across Canada. And so that's actually an indicator that we ended up excluding for that reason. So we just need better quality data. The second point is also that it's only often collected very occasionally and sporadically, which makes it difficult to be able to see long-term trends and to see how service access is being improved and areas where further work is needed. There is also a lot of missing data from particular areas across the country, and notably from the territories. So there are huge health and socioeconomic disparities between Canada's Indigenous and non-Indigenous populations. And the fact that there's so much data missing for the North is really troubling. And it really points to the fact that this is a health justice issue. We also found that there's just insufficient coverage of data. So we ended up excluding some indicators because the coverage just wasn't comprehensive enough to compare across provinces and territories. So for instance, the stats on frequent emergency room visits for help with mental health and substance use were actually excluded from the report because some provinces and territories either had no data or had data that was too sparse to make it comparable. And so a key takeaway was that data does matter. To be able to make system improvements, we need to know which services are being used, by how they're being used, by whom, how often, and whether those services are meeting their needs. Because essentially, if the system is not meeting people's needs, then we're doing something wrong. So this is a lot of information, and now I'm going to pass it over to Sarah to talk a little bit about how we're going to action this information.
You've sold me, Lena, on the value and power of data. And I think we can't make a case to government to change the system unless we know how it's currently operated. And so now we shift into how can we use this report to compel decision makers to change? And in order to answer that question, we need to first know who is responsible for mental health policy. So the question is, what level of government is responsible for mental health policy? I think we'll have some interesting responses here. Already, we're seeing a split almost statistically between provincial and all levels of government. Very interesting. Federal role, absolutely. Municipal, we have one lonely respondent. I see you. I see you. So as folks take a moment to respond, just a reminder, we've had an incredible chat going on, and I'm so grateful for the contributions that folks have made today. As Lena said, we really want to collect these responses and inform future research and policy work in this area, and hopefully inform the type of advocacy work that we do as well when we go and talk to decision makers. Having these examples of best practices and innovations really helps decision makers know where to make those investments in policy changes. All right, so it looks like we've got an inclination towards all levels of government here, and that is correct. While the administration of healthcare is a shared responsibility between the federal government and the provinces and territories, as Lena said, bound legislatively through the Canada Health Act, really all levels of government have a role to play in the delivery and administration and development of policy, allocation of resources when it comes to mental health and substance use healthcare. So when we think of provinces developing healthcare budgets and other related budgets, also municipalities that establish city or town specific strategies, the administration of harm reduction programs as an example, or a mobile crisis response team would be the jurisdiction of a municipality. So all levels of government really have a strong role to play here. And so taking a step back then, what we did at CMHA National was to really reflect on what's the role of the federal government in particular, and that's where we sit. We look at the federal government and really try and work with federal decision makers to inform decision-making around mental health and substance use health, both the allocation of federal resources and the development of laws, policies, and strategies that help guide where those resources should be directed. And what the research tells us is that there's 3 areas of critical concern and where we want our federal decision makers to be focusing their attention. One, it's around making mental health care universal and part of our publicly funded healthcare system. And for us, that means amending the Canada Health Act. As we talked about earlier, it's insufficient and doesn't meet our current needs, and is in fact probably discriminatory in that it treats people with mental illnesses and substance use disorders unjustly compared to people experiencing a physical health related concern. And so we think it's time 40 years later to reopen the Canada Health Act and really look at how we can position mental health and substance use health on par with physical health within our public universal healthcare system. The second piece that shone through this research is really around the social determinants of health. It's ensuring that people have adequate access to affordable housing and appropriate housing, income supports that help keep them well and ensure that we're not having to make tough decisions between putting food on the table and paying rent and then accessing healthcare services on top of that. It's also about tackling discrimination. So Lena spoke quite clearly to the inequities that exist across and within populations, particularly on the grounds of indigeneity, race, sexual orientation and gender identity, gender, and other factors that really mean that our programs and services aren't reaching populations the same way, and that we lack culturally safe and appropriate ways of reaching populations and all their diversity. And finally, data, data, data. We need better quality data that's disaggregated across geographies and demographics. So now we get to turn to you. You've already shared some examples of what what's working well in your communities. Now the question is, if you were talking to your decision maker, and spoiler alert, I think there are some decision makers on the line. And so no pressure, you can be in listening mode right now, whatever level of government you are. Thank you for coming today. The question is to everyone, if you were talking to a decision maker at any level of government, what would you want them to hear about what the system should look like? What types of initiatives should they be focusing on? What would you want the system to look like ultimately? Spend another minute here. Apologies, one-word answers are hard when talking about the complexity of the system. And Lena, just to tee you up, we'll see if we have a question, but one of the questions that came through earlier on was around data availability and being able to look across geographies, rural versus urban, northern versus southern, east versus west, if you wanted to speak to data gaps on that front. Okay, I'm gonna move things along here. Thank you so much. So before we leave you and I turn it over to Lena to hopefully answer a question or two, we really thank you for attending today's webinar, and we are so delighted that you have officially joined us, I hope, in becoming a mental health champion. I suspect many of you already are in the communities that you live and work and play. As Lena mentioned, the report isn't yet available, but it will be available as of November 19th. If you scan the QR code here, and you might have to refresh your browser to get it to work, we will be sending out the report to everyone who joined this webinar on the 19th. So encourage you to do that. The reality is that changing systems that are complex and deeply entrenched take time and energy and resources. And at the Canadian Mental Health Association, we are dedicated to making that change in communities across the country, and we can't do it without your support. So thank you today for the 3,000 people that registered to attend today's webinar, who are now part of a movement, and actually the movement that has been driving this change across the country for decades. Thank you for the work that you do, and welcome to the fold. For those of you who are new, we so thank you for your support today, and look forward to sharing more resources like this in the future. So Lena, with about a minute or two to go, can I pass you that question? Data gaps, can you tell us more about what had to be excluded and why?
Yeah, and I also saw that there's a really interesting question about how to streamline and make how to work with the provinces and territories to make data available. So I can also address that. There are definite challenges with the provinces and territories reporting. And so, part of it is developing partnerships across all levels of government to ensure that they're supported to be able to provide that data and to build strong partnerships for data sharing. So that's part of the challenge. And I saw in the comments that somebody also raised the point that the data systems that provinces and territories are working with are different. And so part of this requires some thinking about how we can streamline the process of data collection across all governments to make data sharing possible. Because oftentimes the data that individual provinces and territories are collecting looks really different. The metrics that they're using are different, the things that they're assessing are different, or evaluating from their healthcare performance are really different. So part of it is establishing common criteria or common indicators across the board so that we're better able to report nationally and by province and territory and make those comparisons across jurisdictions. And as you can imagine, that this does cost money. So it means to develop not only a common framework, but making sure that within provinces and territories that individual health organizations are supported with the technologies and the tools to be able to collect that data and to streamline it so that then they're able to report back and share that data.
And Lena, with a minute to go, thank you for that. Just pivoting to one of the earlier conversations we had around budgets. A lot of questions coming in about, were we looking strictly at health budgets, recognizing that if we take a holistic view of mental health and substance use, we're looking at lots of different ministerial engagements, especially at provincial level. And did we include spending around substance use, health, and addictions?
Yeah, that's actually an excellent question. It honestly depends. When you look at the individual healthcare budgets, it kind of depends how the province and territory reported it. Typically, when you look at the budget line items, usually it was included as part of the overall mental health care spending, but it really depends on how that's reported. And that raises a really good point. When you talk about housing, for instance, we know that there's some really important, pardon, that was my alarm. We know that there are some really important needs for folks with mental illness and substance use healthcare services, and that the crossover into the housing sector is really important, making sure that housing is available. And so that figure doesn't necessarily capture expenditures on housing for folks who have mental illnesses and to support their mental wellness. And so there are other areas that it's very difficult to quantify based on the way that the budgets are reported. But overall, if we were to take a very holistic approach, that it would include those types of social determinants of health as well.
Awesome. Well, thank you so much, Lena, and thank you to everyone who came out today. We look forward to being in touch with you next week with the report. And in the meantime, please don't hesitate to get in touch with Lena if you have any questions. We'll leave the slide up there. Have a great rest of day. Merci beaucoup tout le monde. Ça fait plaisir de vous voir aujourd'hui. Bon après-midi.
Thanks, everyone.